I'm going to give you some broad strokes on how to assess some of the metabolic issues that come up in the patients with advanced prostate cancer. So broad strokes in 10 minutes, it's tough to cover this in great detail. So those are my disclosures. All right, so very simple. This slide is a very simple and reductionist approach to ultimately metabolic adverse effects, not cardiovascular disease effects as listed on the slide. So surgical castration leads to an increased incidence of type 2 diabetes mostly. The LHRH agonists relate to weight gain, hypertension, increased blood glucose, and the antagonists relate to more hypertension. Now, these are general summary kinds of things, and we covered the cardiovascular disease issue a couple days ago. So let's proceed. You know, the issue is not simply the weight gain, which is not substantial, and I'm going to show you some data in a second that shows that this doesn't change much early on, but yet, in fact, body composition does. So when we think about increases in adipose tissue, we tend to think about sarcopenia at the same time. And I'm sure your patients, particularly those who are more cachectic in terms of their presentation and management, are going to manifest some of these things. So ultimately, increasing adipose tissue relates to all the things on the upper right. In terms of the weakness and lean body mass loss that occurs below is really a concern. Actually, that's a general concern for aging, isn't it? I mean, frailty, falls, et cetera, that can negatively impact natural existence and also have a relationship to all-cause mortality. Now, this is an interesting study done by Dave Nathan at the MGH in the metabolic unit there at the MGH, who looked at 12 weeks of treatment in patients with androgen blockade and using the drugs as noted there. And it's interesting, you know, the slide is small, but I'm just going to emphasize the fact that weight didn't change at 12 weeks, but fat increased, percent fat increased, lean body mass fell, hyperinsulinemia was present. Using the Bergman model to assess insulin sensitivity, reduced insulin sensitivity, and ultimately the HOMA-IR, which is a crude index of insulin sensitivity that typically is used for population science, also was modified adversely. The lipids are kind of interesting. The total cholesterol went up, but it's interesting kind of that the HDL cholesterol went up, and that's a little bit hard to understand. And just to go tangential for a second, the HDL cholesterol levels, although it's important in terms of risk for cardiovascular disease, the story is kind of changing with HDL more recently, particularly with very high levels maybe causing an adverse effect. So those are 12-week changes without a change in body weight. And you know, with the metabolic syndrome concept, ultimately waist circumference becomes a much more important issue than BMI or measuring the weight in the clinic. Okay, so if we look at androgen deprivation therapy on the left part of the slide, we see we have alterations in lipids, which I just alluded to very briefly, the development of insulin resistance, and the risk for diabetes. And by the way, the metabolic syndrome, I'm going to cover a little bit more detail in a moment, but the metabolic syndrome is effectively insulin resistance. It explains almost all the features. And to the right are issues that relate to the development of defects downstream that will relate to cardiac contractility and ultimately the development of heart failure. So both of these at the bottom right can end in cardiovascular morbidity and mortality. So ultimately, if we look at insulin sensitivity measurements during combined androgen blockade therapy, we're looking at defining the metabolic syndrome before we assess it clinically. And this is pretty simple stuff. I mean, this is a syndrome, it's not a disease. So it's been defined earliest by Jean Vague in Paris in 1947, and then revisited by the World Health Organization in 1998. And I was sharing in the International Harmonized Definition of Metabolic Syndrome with my colleague Georges Alberti from the UK. Anyway, 3 of the following components based on waist circumference. Now keep in mind, it's where you put your fat that's more important. In fact, sparing subcutaneous fat in the extremities is equally as important as putting it intra-abdominally. So that's one of the criteria. The criteria are different for men and women, and they're altered around the world. Southeast Asians have a much greater risk with lesser waist circumferences, so this has to be population-based. Triglycerides above 150, HDLs less than 40 in men, under 50, and blood pressures above 130 over 85 are being treated with an antihypertensive agent. Fasting glucose is above 100. And if you look at the predictors of type 2 diabetes that relate to the metabolic syndrome, it's entirely driven by the fasting glucose. All of the other components of the metabolic syndrome do not relate to diabetes. So here's a cartoon that's been modified since our paper in the Lancet many years ago, but this model's not changed very much. So it starts with excess adipose tissue. These free fatty acids that are released excessively when adipose tissue expands drives the liver into producing atherogenic lipoproteins. It drives it to make the prothrombotic state, including fibrinogen. It also drives insulin sensitivity defects in skeletal muscle. Insulin only works in skeletal muscle and the liver and in adipose tissue. It doesn't work in any other organ of the body. But these fatty acids cause harm through mechanisms that are directly related to glucose and indirectly related to downstream signaling of insulin in various tissues. And hypertension, to a large extent, relates to fatty acids that modify vascular reactivity. Now, when we think about the metabolic syndrome, this is really a syndrome that relates to insulin resistance. It goes far beyond the definition. So we're looking at inflammatory markers. We're looking at the presence of liver disease, so-called non-alcoholic fatty liver disease. We're looking at hyperuricemia and polycystic ovarian disease, not present in the men, obviously. And to the right, cigarette smoking, sedentary behavior. The lipoprotein changes are not simply high triglycerides and lower levels of HDL, but they relate to particle distribution that is abnormal and proatherogenic. And then the prothrombotic factors I alluded to before. Anyway, insulin resistance is not simply 3 of the 5 criteria that are used to define the metabolic syndrome. And this has been well defined by the science. Now, the metabolic syndrome is not getting any better. We're seeing data here for white men. We're seeing data in orange for black men. We're seeing data for Mexican-American men. And as we see over the NHANES database over the last few decades, ultimately the metabolic syndrome is increasing. And with that increase in the metabolic syndrome, we're seeing some racial disparities in terms of people with prostate cancer with androgen deprivation therapy, where the black race, you see much more cancer in your black patients, but the risk for diabetes is about 4% higher. It's highly statistically significant in people with androgen deprivation therapy who in fact are followed forward with a metabolic syndrome. Now, that gets to the point of kind of how we go about treating, having your urologist think about this in the clinic. We don't want to make you primary care physicians or cardiologists or endocrinologists, but there's some simple things to do. And Dave Crawford and I, with the 360 process, have a paper under review now to look at the approach to cardiovascular disease, but some of this has already been published. So do you have a history of chronic kidney disease? A very straightforward question you should be asking anyway in your prostate cancer patients. And are you currently taking any of the following medications? Cholesterol-lowering drugs, by far statins, and I didn't mention this 2 days ago, but statins should be more frequently implemented in many of your patients. Aspirin or other medications to affect clotting. Obesity medications are becoming much more common. I commented on that the other day. GLP-1 receptor agonists work in a tremendous manner. And I saw a paper this morning that indicated bariatric surgery, which does great things for metabolic syndrome and risk for diabetes, appears to be better in terms of what it accomplishes with Roux-en-Y gastric bypass than with the sleeve procedure, which is currently being used more frequently. And of course, diabetes medications. So this follow-up is not simply, just do it once and kind of let things ride, but of course the PCP should be very much involved in the management of these patients. So these are the kinds of things to think about. Family history needs to be gathered by history. A1C is important, obviously, in assessing people with prediabetes. By the way, 83 million Americans have prediabetes. EGFR should be followed, weight, et cetera, waist circumference. And 10-year risk we talked about several days ago, using the risk calculator for that. Now, the interesting thing, if we look at a meta-analysis here of 33 studies, including 17 that did interventions with exercise only and 10 more that included diet and exercise, basically, I'm going to just summarize this for you. But with this type of an intervention in the clinic, ultimately body fat changed, waist circumference changed, systolic blood pressure fell, and diastolic blood pressure fell without really tremendous changes in a lot of the other metabolic factors. So this kind of an intervention at least makes sense in terms of modifying some of the risks for cardiovascular disease and diabetes. So let's summarize. Patients with metastatic prostate cancer may experience adverse metabolic adverse effects, changes in weight, body fat distribution, metabolic syndrome, glucose intolerance, and type 2 diabetes. Lifestyle changes can improve some of these adverse effects. That's not your job. And finally, unfortunately, the prospective data remain inadequate, and randomized controlled trials are desperately warranted to assess best approaches for outcomes. And let's stay hopeful, as mentioned last night. Thank you very much.